I'll request Dr. Callans to come over and talk about ventricular tachycardia storm management. Thank you.
Thank you. Good morning. Thank you again for this kind invitation. I wanted to talk about this in broad strokes, although there's a case involved too. Trying to get across the point that this is something that we deal with more frequently than I used to think. It was always pictured as some sort of elusive thing. Ventricular tachycardia storm really didn't happen that often, and it was a sincere emergency when it did. But unfortunately, these are the patients that we're seeing day in and day out for catheter ablation. And one of my favorite tirades is trying to picture the world, what it would look like to prevent ventricular tachycardia storm by approaching these patients a lot earlier in the disease process. It's probably a good idea, but that's a different topic. So what is VT storm? So it's a mixed population of arrhythmias and also of the underlying structural heart disease. So VT storm can happen with ventricular tachycardia that's uniform, usually in the setting of severe structural heart disease, a lot of scar burden, and usually significant clinical heart failure. Or ventricular fibrillation, which can be different, can be the same, can be patients with structural heart disease or electrical heart disease, or even idiopathic ventricular tachycardia. Technically, this diagnosis is greater than or equal to 3 VT or VT episodes requiring treatment in 24 hours. Sometimes people break this speed limit considerably. There's not really been a definition that's decided about whether this refers to appropriate shocks or ATP. It is really a diagnosis primarily in patients with pre-existing defibrillators, at least in the States. Estimated incidence, 3 to 4% of patients who receive primary prevention ICDs. And I don't like the spread very much, but it is the spread over a couple of different surveys, 10 to 40% of secondary prevention ICD patients, so not all that unusual. It is importantly associated with increased mortality, recurrent storm, and an increased risk of recurrent ventricular tachycardia, even with very aggressive therapy. I have a couple of surveys of this from the literature just to round this out a little bit. This is a study reported by Verma, which I think is probably among the most contemporary of the ones that I'll show, and importantly shows how mortal a disease this is. So in their series, 10% of patients with ICD therapy presented in storm, and there was no particular difference in mortality whether these patients had ventricular fibrillation or ventricular tachycardia as the cause of their storm. And these mortalities are pretty bad. If you look at the control group, can't get that to work. If you look at the control group with ICDs without storm, there's some incidence of mortality, but VT or VF storm makes this mortality considerably worse. This is an interesting study in dilated cardiomyopathy patients with ICD, and really an example of spectacularly poor mortality. I would argue, perhaps because it's a little bit of an older study, but also there's a very poor incidence of ablation treatment of these patients. So if you look at VT clusters, which I think is an analogous term for storm, in 106 patients with dilated cardiomyopathy, there were 30 patients who had storm. Survival without transplant at 1, 2, and 3 years was only 57%, 46%, and 31%. Pretty desperate. But again, catheter ablation was only applied in 2 patients of the 52, and both were unsuccessful. I use this maybe unfairly to make the point that management of this is going to end up being cooling these patients off, as Doug suggested, and then ablating what the problem is. So it's an electrical disease in the setting of advanced structural heart disease. The electrical heart disease doesn't go away in any other way but with ablation. In AVID, there were 487 patients treated in the ICD group. 90 patients, 18% of these presented with VT storm. Again, very high risk of mortality, particularly up front. 5.4% mortality in the first 3 months, and then 2.4% overall yearly mortality after that. So again, this idea of a window period of when we can get at these patients and potentially at least impact their prognosis very well. Interestingly, in this series and in most others, patients who present with VT storm, it's a cry of help that their heart is dying, and the mode of death is usually heart failure. I think we participate in that a little bit. And this is reading between the lines, but if you have a patient who has a lot of ventricular tachycardia, ventricular fibrillation, and we give them medicines that are helpful for management of arrhythmias, but probably hurtful for poisoning myocardial performance, or if we add ICD shocks on top of that, it does influence negatively heart failure mortality. The authors in AVID stress this window for intervention, looking at everything, taking care of the arrhythmias, treating heart failure better, treating ischemic heart disease better. It made it to a little bit more contemporary. There was a very much more perfect incidence of modern heart failure therapy. They looked at 700 primary prevention patients, and 4% of these presented in the short period of the MEDA2 program with VT storm. In these patients, the adjusted risk mortality was 17.8 in the first 3 months and 3.5% annually afterwards. Again, almost all of these deaths were non-sudden, so this is kind of a heart's cry for help in the setting of structural heart disease. There was also a marked increase in the VT storm patients of subsequent heart failure hospitalizations. So we get this general sense that it's an electrical thing happening in the setting of a lot of other things going wrong with the heart in general. So maybe then there's this general sense that there are arrhythmias, but the arrhythmias are being forced upon the heart by other things going wrong. I'd like you to believe that it's the other way around, but this is definitely the conventional wisdom, that if we could get rid of the heart failure, get rid of the ischemic heart disease, everything would go away, the electrical disease would be fine. So the general perception is that those two factors, heart failure exacerbation or acute ischemic heart disease, is really what drives the majority of this bad train. They looked at this in a SHIELD study and identified a cause that was plausible for VT storm in about 13% of patients, and heart failure was the provocateur in 9%. In MEDA2, post-enrollment myocardial infarction or post-enrollment in angina increased the risk of storm. And interestingly, of the 27 patients in MEDA2 with storm, 7 of them had storm within 4 weeks of an ischemic event. Isolated episodes of VTVF and also renal insufficiency predicted storm in MEDA2. But none of this really carries the day. There are co-travelers, but this is an electrical disease that happens in the setting of advanced structural heart disease. The electrical disease has to be taken care of. How do we take care of that? Well, antiarrhythmic drugs have some role in this, but I think in a confused way. There was a very interesting program that led to the FDA approval of intravenous amiodarone, 3 separate studies, all kind of aimed at this group of people. So IV amiodarone given for recurrent hypotensive VTVF, practically stormed, randomized to 3 doses, and survival at 48 hours was 80%, 60% at 30 days. So this is really a desperate population. As we gave IV amiodarone, VT and VF events decreased with increasing doses, didn't necessarily go away in all the patients, but got better. So why does this help? So we think of amiodarone as our most powerful antiarrhythmic drug. I think in this setting, and very importantly, and a theme that will be developed in future slides, amiodarone is our best beta blocker. And the only way that we can medically treat VT storm, whether it's ventricular tachycardia, ventricular fibrillation, is by effects on the sympathetic nervous system. This is an interesting paper that's very small that our group put together, looking at VT storm caused by biventricular pacing. This is kind of the index patient that I really love. So we see that ECG of essentially VT interrupted by occasional paced beats. Pacing is bi-V pacing. We turn off LV pacing, and the VT goes away. This is happening in real time as proof of concept, and because we're all deeply scientific, we've turned the biventricular pacing back on, and the VT comes back, and so on and so on. We eventually elected to turn the bi-V pacing off. So this is not a great frequency of patients, but it can be an important thing, and we look at this as being the induction of reentrant tachycardia is by stimulating from a different site. So if you turn off that site, sometimes even if you change the position of the bivalve pacing electrode by a couple of centimeters, it's an entirely different story. So ventricular tachycardia and structural heart disease has a site-dependent characteristic of induction. We think this is biventricular pacing inducing VT. It can help sometimes. Autonomic intervention for VT storm I already mentioned as kind of an introduction with amiodarone. This is a very important paper from the UCLA group looking at 14 patients with VT storm refractory to medical therapy, meaning beta blockers and antiarrhythmic drugs, and often multiple catheter ablations. What next? So in this series, thoracic epidural anesthesia and left cardiac sympathetic denervation was performed. With thoracic epidural anesthesia, 6 of 8 patients had a greater than 80% reduction in episodes. With left stellate ganglionectomy, there was no VT in 3 patients. VT resolved within 24 hours, responded to ablation after ablation had previously failed in 2, and recurrent VT was seen in 4. So these patients were essentially dying of ventricular fibrillation or ventricular tachycardia and got better with autonomic intervention. Problem is they're very sick with structural heart disease, very sick with electrical heart disease. Only 9 of 14 survived to discharge. 1 patient required urgent transplant. So a very sick group of people that were helped by autonomic intervention. Could we do this earlier? What is the right setting to put this in? Shiv is putting together a trial looking at this intervention with particularly left stellate ganglionectomy after an initial failed VT ablation in patients with structural heart disease. So again, the concept of moving this desperate therapy more and more upstream to see if we can prevent people from being in this awful situation. Doug, I think, showed this picture yesterday. Renal denervation in VT storm. This is 2 patients. There are more coming. There are more case reports coming. This seems like it would be an easier way of dealing with this. So in this particular publication, I think the interesting thing was there were 2 patients, both had heart failure, structural heart disease. One had VT, one had VF. And I hope I show this. I don't. But the amazing thing, and I guess it's at the bottom here, the amazing thing in both patients is there were tons of episodes of appropriate shocks pre-procedure. And immediately post-procedure, the episodes didn't go away. They were markedly reduced. But seemingly talking about remodeling, it takes several days to weeks for the VT to go away completely. So there's no change in therapy after renal denervation. But the immediate effect was marked, but not complete. So it took a little bit of time for this to really come full swing. Interestingly, in these patients, it was nothing about hypertension, I guess, obviously. They were the typical patient with heart failure with very marginal baseline blood pressure, and renal denervation did not worsen blood pressure response. This is interesting and maybe a hypothesis-provoking sort of argument. I think the majority of treatments that have been really studied for this population of patients in the recent era is catheter ablation. Probably the most successful of these studies is a Milan study looking at 95 consecutive patients with refractory VT storm, all in structural heart disease. There was, interestingly, a limited impact of substrate-based ablation. Only about half of patients received this. VT induction was prevented after ablation in 85% of patients, although some required additional procedures. And over 22 months, there was a good freedom from recurrent VT storm and an 88% survival. Acute success was associated with decreased mortality, decreased VT recurrence, and the absence of VT storm. This is what this looked like in a Prague study of 50 consecutive patients, very sick patients, again, with structural heart disease, a mean ejection fraction of 29%. Ablation prevented VT induction in only 44% of patients, but there was acute prevention and acute management of the VT storm in 84%, and overall a 74% freedom from recurrent VT storm and a 72% survival, which is a lot better than previous surveys without catheter ablation. Predictors of mortality in this basis was the need for transplant, low EF, increased LV-sized, renal disease, and recurrent VT storm. What about PVC triggers for primary ventricular fibrillation? So this work has already been presaged by Doug's talk as well. So primarily electrical heart disease or even idiopathic ventricular fibrillation, a little bit different look, can happen in patients without severe structural heart disease. This is the Hasseger data. They focused on this idea that this was very often Purkinje related. With the LV Purkinje network, usually distal, the RV Purkinje network or the RV outflow tract. The PVCs that started ventricular fibrillation were very often early coupled and behaved interestingly. So they could exit to the myocardium at different coupling intervals in terms of the Purkinje spike to the V, and then those different coupling intervals would have different morphologies. It was very difficult to treat this with pace mapping. It was really all activation mapping, looking at these sites, kind of having the catheter close there, but really finding the exact site that gave rise to these different morphologies. In 27 patients, 24 were free from recurrence off antiarrhythmic drugs at 2 years. This is kind of expanded in a little bit different look at it. PVC triggers for VF, which looked the same, but occurred in patients with healed myocardial infarction. This looked at 26 patients from 4 centers who had recurrent ventricular fibrillation despite revascularization, despite intravenous amiodarone, that occurred early or late following myocardial infarction. And the triggering PVCs were usually mapped to sites with Purkinje potentials that were usually located at the infarct border between normal and abnormal tissue. Multiple ablation lesions were issued, and kind of the finding was to make sure that ablation was continued until PVCs were absent. Acute success in all but 1 patient, and freedom from VF in follow-up in 23 of the 25 successful patients. We've been staring at this a little bit, and I wanted to show just a quick case. We've been finding that in 30 patients with PVC-triggered VF, causing VF storm in about half of those, that the most important part of this seems to be the usual sites, but particularly the papillary muscles, both in the left ventricle and the right ventricle. And this is kind of disastrous, as people that do catheter ablation for the papillary muscles know they're very difficult to understand. This is a quick case I'll run through quickly. A patient with a resuscitated VF arrest in the absence of structural heart disease had a single chamber ICD implanted elsewhere and had recurrent PVC-triggered VF episodes resulting in ICD shocks. Very often had non-sustained polymorphic-looking VT recorded on ICD electrograms, but also had shocked events. This is what happened in the laboratory, just frequent episodes of polymorphic VT. They were all indexed by the same PVC at initiation. That PVC was very early coupled to the preceding sinus beat. The earliest site of activation for these PVCs was at the moderator band. So the moderator band is richly invested with Purkinje fibers, but is a very specific anatomic place that's difficult for us to map. It's free-floating and very three-dimensional. We find ways of trying to understand this anatomically is by making a separate chamber map of the moderator band itself. We feel that this is very importantly kind of put into mind where this is by looking at the interaction of the catheter on the moderator band structure using intracardiac echo. So very often we'll make a map, activation map with these chambers, but aim anatomically at the moderator band. Here we're looking at the moderator band as it inserts into the free wall of the right ventricle with ice. Often, as Doug just stated in his talk, ablation here causes a lot of ectopy, which can be really frightening, but has to continue, like you said. The lesions are not, we don't spare the lesions. We try to be precise about where we're targeting, but because the odds of being wrong are very high, we kind of give a lot of bonus lesions. So 2 more slides. Sorry, I'm running over a little bit. Evolution of therapy for VT storm. It's important to realize that there are no real randomized trials in this. And the natural history in the current age is unclear, but we have a suspicion that it's relatively evil. Autonomic effects are important. Beta blockers we used to look at as heart failure treatment, and they are importantly, but in this setting, beta blockers are to turn the sympathetic drive off. IV amiodarone is a much more successful way of doing this than conventional beta blockers. Sedation trumps IV amiodarone. General anesthesia trumps sedation. And it's a little bit too soon to make this declaration, but I suspect that neuraxial intervention is even more strong and more permanent than general anesthesia. Catheter ablation is important to prevent the need for potentially harmful drugs and for shocks. And I think advanced heart failure intervention should at least be thought of in these patients. VT storm is a sign of the dying heart. So there are people that are having VT storm as an electrical disease, and there are people that are having VT storm as end-stage heart failure. And sorting between them can be a very difficult thing. Usually we treat both, but sometimes one takes precedence over the other. So trying to cull this all into a treatment algorithm for VT or VF storm. I think it's important to distinguish patients with primary ischemia, especially those with polymorphic VT or ventricular fibrillation, and often revascularization can be curative. I think it's important but difficult to distinguish patients who are dying of heart failure, in which case left ventricular LV assist devices may be the way out of this, although there'll still be arrhythmias to contend with. The urgency of the situation can be maintained by treating the heart failure. Maximal medical therapy, meaning maximal taking care of the sympathetic drive. Sedation and general anesthesia if necessary. Catheter ablation, but the more electively this can be performed, the better. So there's a sweet spot here. So storm has a limitation in time. You don't want someone coming to the lab that's getting shocked every 10 minutes, but neither do you want someone who's recovered completely and is not having any PVCs anymore. And making that window period can be very difficult to plan. I think autonomic intervention is the frontier in this, and I think will continue to be more and more important as we go forward. Thank you for your attention.